It's a great pleasure to be with you here today. I'm on call at the moment in the hospital, so I missed some of the talks, but what I have heard has been outstanding. And one theme that has come up recurrently, obviously, is activity and exercise after SCAD. So I'm going to kind of emphasize some of the points that have been made already and do a little bit of a deeper dive into some of these topics. Here are my disclosures and affiliations, which are not relevant to this talk. So this has been shown already today, where the current gaps are in our understanding of SCAD, and the one I will highlight here is the causal role of exercise pre and post SCAD events. And yet, when we ask patients what is the most important, or one of the most important pieces of information that they want to learn to support their recovery after a SCAD event, it relates to physical activity and what is safe for them to do after these kind of events. So how are we doing? Well, this was a survey of a registry of 950 patients who had a SCAD event, and actually when you look at this, it doesn't look too bad. So this is the initial visit that when people come after a SCAD event, and almost 3/4 of them do report getting an exercise prescription, with only a very small minority getting discouraged from exercise. But when we dig into this a little bit more and kind of ask, well, what is an exercise prescription? And you look at the kind of advice people have been receiving in terms of the type of exercise, the intensity, the frequency of their exercise, these numbers really start to fall off. And so I would submit that maybe this is not a complete exercise prescription, and we'll talk about what that should look like. But why is there concern there at all? Well, there has been a concern that exercise does precipitate spontaneous coronary artery dissections. And, if you look at this registry again of 22 North American centers, about 30% of people do report unusual physical stress prior to their SCAD event. But the reality is that most of these are spontaneous and unrelated to exercise. And even the ones that do report in this, it was kind of an event that happened within a week of exercise occurred within a week of the SCAD event. And when we kind of think mechanistically about this, we're proposing that have an underlying vulnerable vasculature, and then you have this mechanical precipitant being exercise. So you've got the increased pumping function of the heart, the increased heart rate, higher blood pressure as people exercise. And then when you've got these tortuous blood vessels that are vulnerable, that may precipitate the SCAD event. But it's a little bit difficult for me to accept that someone who did some exercise a week before their event, that's the true mechanistic theory behind that. What we do know, though, is that exercise is extremely beneficial in general. As we exercise more, our risk of cardiovascular events goes down. But even outside of our cardiovascular risk, exercise is extremely important for us from a social, a mental health, and an emotional perspective as well. And we also know that exercise can be very beneficial even in the context of patients who have had spontaneous coronary artery dissection. So it lowers blood pressure, it lowers systemic vascular resistance, improves autonomic nervous system, lowers sympathetic adrenergic drive, and improves endothelial function. All of things that we really want to happen in our patients with spontaneous coronary artery dissection. So we have this kind of area where we've got this risk of exercise in patients who have had SCAD that really is unknown. Most patients will never have another SCAD event. And then we have the benefits of exercise, which we know about. And so how do we kind of balance that? How do we advise patients? Well, unfortunately, historically, we have taken a very, very conservative approach. And what I'm showing here is what were used to be called the Bethesda guidelines for competitive athletes, disqualification eligibility guidelines for athletes. And patients who had a SCAD event were really restricted quite a lot in this format. And what physicians have done in the absence of any other data is they've gone to the competitive athlete data and said, oh, they're being really restrictive in this cohort. Let's be restrictive to all of our patients. And so it's been a very conservative stance that doctors have taken over the decades in terms of giving people advice about this. I'm glad to say that this has been updated, and in 2025 we did publish new guidelines, and they've gone away from the disqualification and eligibility construct to clinical considerations for competitive athletes. And we can see a couple of things here in spontaneous coronary artery disease. One is, again, emphasizing the importance of cardiac rehab, but then really focusing on counseling about the benefits of regular aerobic exercise. And then finally, for competitive athletes, having some caution there. The risks may outweigh the benefits in some athletes, but it does leave some scope to individualize that recommendation based on the athlete themselves and the sport that they want to participate. But for most of us, it's not talking about competitive athletes or competitive sports, it's more talking about lifestyle. And so we really have tried to move away from this idea and algorithm or paradigm that we're going to restrict people to trying to give people prescriptions. And so my approach is the same as what many others have said here. Really, first step is to recommend cardiac rehab. And I think there's a number of components to this. One is that there's good, strong data showing that people live longer if they do cardiac rehab. It's safe. And so there's no adverse events in people who have done cardiac rehab. But I think one of the big things in my mind, and some of the patients have mentioned this, is just the confidence that it builds up. And so a severe shock to people who've been extremely healthy and active all their life to have this problem. And so it can be very, very nerve-wracking for people to return to any kind of exercise, and so cardiac rehab can really help with that. And there are a number of published criteria that we can use. This is one from Vancouver, there's one from Mayo Clinic, and these can be a helpful construct to help us think about this. Some of these I don't particularly agree with. For example, patients are advised to avoid lifting weights greater than 20 pounds, and we'll talk about that in a moment. So after cardiac rehab, then, well, it's what next should we do? And so I really think we need to spend a little bit of time understanding our patient, who they are, what they enjoy doing, and how important activity is to them. You know, what is their main goal from activity? Is it that I want to stay fit and I want to stay active, I want to maximize the benefits of exercise but minimize the risks of it? Or is it like, if I don't do this type of exercise, I'm a basket case? And that happens to many of us, where if they can't do something that they built their life around a particular activity, and if they can't do it, their life really falls apart. And that has to fall into the advice we're giving people. So that's something we'll talk about a bit. And then, you know, what is the individual's risk aversion or acceptance of risks? You know, if you're a patient who likes to jump out of airplanes without a parachute and land in a net, as one of my patients does, they're talking to them about the risk of jogging doesn't really make sense. They've got a very different sense of risk than many of us. The next step then is to talk about, well, what actually happens to our hemodynamics when we do different types of exercise. And I find that patients find this really helpful. So when we're doing pure aerobic exercise, we get this increase in cardiac output and a gradual increase in blood pressure. But usually blood pressures, even in young athletes, are fairly modest increase, and the body can really tolerate these. So endurance, pure aerobic exercise, generally we get a very controlled increase in our hemodynamics. Strength training is different. We can get very intense short bursts in blood pressure. This is an intra-arterial blood pressure trace of someone who's doing 11 reps to failure. And you can see that the cutoff here is 400 millimeters of mercury. So we can really dramatically increase our blood pressure with these kind of very high intense strength training. And then the mixed kind of exercise falls somewhere in the middle there, the kind of cycling and rowing. And so there are multiple factors we need to think about. The first is the underlying fitness or strength of the individual that we're actually dealing with. I think this was very eloquently shown here. On the x-axis, we have kilograms, the amount that was lifted. Up to 300 kilograms this individual was lifting, and this is the blood pressure profile, versus this individual who's lifting just over half of that, and the blood pressure was much higher. So this person was just much stronger than this person and was able to lift a lot more. And so this idea that everyone can only lift 20 pounds, irrespective of whether you're this football player or a little old lady, doesn't make any sense to me. Also, then it depends on what's the percentage of muscle that we're lifting. So a double leg press is going to be a different hemodynamic effect than if we're doing a single bicep curl, for example. And then the maneuver also, it will depend. You know, if you're doing a 20-pound lateral arm raise versus a double leg press or push, that's a very different stress on the system. So again, I think using just a single weight cutoff doesn't really make a lot of sense. And this is where we need to just give guidance in terms of intensity for these kind of weights. Valsalva, where we bear down, we can see that when we do that, each time we bear down, we get this big spike in blood pressure. And then when we're lifting to fatigue, where we end up in our last few weights, again, we see these big spikes in blood pressure. So again, I spent some time talking to people about, you know, these different effects and how we can use this to give a prescription. We're lucky that we at Sanger, at Advocate Health, we've got the Gregg Center for Cardiovascular Performance, which we were able to create with a very kind donation from a patient, where we have 2 cardiopulmonary exercise labs, and we can use this to actually give very personalized prescriptions for exercise. And when we're doing a prescription, I really encourage everyone to be a little bit more well-defined in what we're trying to achieve here. So rather than just saying go and do some regular moderate exercise, actually use this FIT algorithm. So frequency, 3 days a week, up to 6 is optimal. Intensity. Now aerobic, I've changed my thinking on this over time. I really think we've probably been a little bit over restrictive in this. I try to keep people out of submax training for aerobic. Resistance, we keep it to mild to moderate intensity, and then mixed training, the cycling and the rowing somewhere in the middle. But again, it does depend on that individual's desire to exercise and their underlying risk profile. And then we want to give them a time where ideally less over 150 minutes, optimally 300 minutes. And then we talk about the different types of exercise, the benefits of aerobic exercise, some of the risks and concerns about resistance exercise, but also recognizing that we have to do some resistance exercise. We have to maintain healthy muscle strength over time. So we have to do some of that and just talk about what that should look like, and then do some balance and flexibility. So I think it's important that we emphasize the importance of exercise, and that most SCAD events occur outside of the context of exercise. Again, we're emphasizing the importance of cardiac rehab, sharing with patients the different effects of the different types of exercise on their hemodynamics and risks, and then try to give a specific exercise prescription using this FIT algorithm. And we can kind of move from this older paradigm of restriction to prescription for these individuals. Thank you.